Good day, everyone. So for today, I am going to discuss about the developmental defects of oral and maxillofacial region. Orofacial clefts. The formation of the face and oral cavity is complex in nature and involves the development of multiple tissue processes that must merge and fuse in a highly orchestrated fashion. The disturbance in the growth of these tissue processes or their fusion may result in the formation of orofacial clefts. Development. Development of the central phase begins around the end of the fourth week of human development with the appearance of the nasal olfactory placodes on either side of the inferior aspect of the frontonasal process. Proliferation and ectomesenchyme on both sides of each placode results in the formation of the medial and lateral nasal processes. Between each pair of processes, it is a depression or nasal pit that represents the primitive nostril. During the 6th and 7th weeks of development, the upper lip forms when the medial nasal processes merge with each other and with the maxillary processes of the first branchial arches. Thus, the mid-portion of the upper lip is derived from the medial nasal processes, and the lateral portions are derived from the maxillary processes. The lateral nasal processes are not involved in the formation of the upper lip, but they give rise to the alley of the nose. Primary palate. So, it is formed by the merger of the medial nasal processes to form the intermaxillary segment. This segment gives rise to the premaxilla, a triangular-shaped piece of bone that will include the four incisor teeth, while the secondary palate, which makes up 90% of the hard and soft palates, it is formed from the maxillary processes of the first branchial arches. The defective fusion of medial nasal processes with the maxillary processes leads to cleft lip. In failure of palatine shows, the fuse leads to cleft palate. The lateral facial cleft is caused by the lack of fusion of maxillary and mandibular processes. The median cleft of the upper lip, a specific and rare entity on the spectrum of facial clefts. It is an extremely rare abnormality caused by abnormal fusion of the medial nasal processes. So, median cleft of the upper lip have different clinical expressions and can be either isolated or part of multiple malformation. Causes of orofacial clefts. Associated in syndromes, they have autosomal dominant, autosomal recessive, X-linked inheritance pattern. Second one, the genetic factors, TGFA, TGFB, and TGFB3. Environmental factors, the maternal alcohol consumption, maternal cigarette smoking, folic acid deficiency, corticosteroid use, anticonvulsant therapy. Clinical features. Cleft lip, that's negative C. Cleft palate is more common in males. Cleft palate only, or the CPO, is more common in females. 80% of cleft lip are unilateral. Cleft palate shows variation in range. It may involve hard and soft palates or soft palate alone. In some instances, cleft exists beneath the intact mucosa, submucosal palatal cleft. Pierre-Robin sequence, the PRS. So, it is a condition with multiple causes. It is a congenital defect observed in humans which is characterized by facial abnormalities. Cleft palate is also commonly present in children with Pierre-Robin sequence. It is a rare congenital birth defect by an underdeveloped jaw, backward displacement of the tongue, and upper airway obstruction. It's a well-recognized presentation characterized by cleft palate, mandibular micrognathia, glossoptosis. The retruded mandible results in posterior displacement of the tongue, lack of support of tongue musculature, airway obstruction. Treatment and prognosis. multidisciplinary approach. The pediatrician, OMF surgeon, plastic surgeon, pediatric dentist, orthodontist, speech pathologist, and geneticist. Primary lip closure is usually accomplished in first few months, followed by repair of the palate. Prosthetic and orthodontic appliances may be used to mold growth, and late bone grafts are placed in area of bone defect. Fordyce granules. So, Fordyce granules or spots. These are sebaceous glands occurring in the oral mucosa. So, it is a collection of sebaceous glands that occurs in various locations in the oral cavity. They are present in almost 80% of the population, so these are considered as normal anatomical variation. Multiple yellow or white papular lesions common on buccal mucosa and lateral of the vermilion of the upper lip. Present in adults as a result of hormonal factors, puberty is a major factor in it. Fordyce granules is asymptomatic. Histopathological features in Fordyce granules. So these are similar to the normal sebaceous glands except the absence of hair follicles. Acinar cells are present beneath the surface. The sebaceous glands in these lobules are polygonal in shape, containing centrally located nuclei and foamy cytoplasm. The treatment. As these are asymptomatic and a variation of normal, so they don't need any treatment. Sometimes they become hyperplastic and filled with keratin. Leukoid edema, a common oral mucosal condition of the unknown cause. According to Sunstead and Lowy 1 in 1953, this disorder of the mouth affects the buccal and labial mucosal surfaces. Blacks and white, they are blacks and white. So a variation of normal anatomical structure rather than a disease. Its clinical features. So it is characterized by the diffuse, gray-white, milky, opalescent appearance of the mucosa. The surface usually appears folded, showing wrinkles. Lesions present bilaterally and do not rub off. It can be easily diagnosed because wrinkles disappear when the cheek is everted. His pathological features. So it increases in epithelial thickness with intercellular edema of spinous layer. Cells appear large and have pycnotic nuclei. Surface or parakeratinoids and radial ridges are broad and elongated. Its treatment is it is benign condition which requires no treatment. Microglossia. So it's a developmental disorder characterized by an abnormal small tongue. The entire tongue may be absent, aglossia. It may be associated with some syndrome or other anomalies like cleft palate, intraoral pants. It is frequently associated with hypoplasia of mandible and sometimes incisors may also be missing. Macroglossia, a common condition characterized by abnormally large tongue. Causes: congenital and hereditary, vascular malformation, hemangioma, lymphangioma, cretinism, Down syndrome, mucopolysaccharidosis, multiple endocrinoplasia. It's acquired edema patients, amyloidosis, acromegaly, angioedema, myxedema, carcinoma. Clinical features mostly present in children and its severity ranges from mild to severe. It manifests by difficulty eating, drooling, and noisy breath. It may create a crenated lateral border of tongue, open bite, and mandibular prognathism. It may become ulcerated and become secondarily infected. Its histopathological features. It depends upon the cause. No abnormality in case of syndrome. If it because of tumor, then microscopic features of tumor will be shown. In amyloidosis, abnormal protein material is deposited in the tongue. Treatment. It depends upon the cause and severity. In mild cases, surgery may not be needed, but speech therapy is required. In severe cases, surgical reduction will be treatment of choice. Maxillofacial, also known as tongue tie, a developmental anomaly of tongue characterized by a short, thick lingual frenum resulting in limitation of tongue movements. Clinical features. Its severe ranges from mild cases of no significance of severe cases with almost fused to the floor of mouth. Limited movement of tongue creates problem in speech and eating. May cause problem in breastfeeding. Treatment. In mild cases with no functional problem, no treatment is required. In infants with with problem in breastfeeding, frenotomy or release of frenum. In adults with functional problems, frenoplasty, it is surgical repair of frenum. It is the treatment of choice. The condyle hyperplasia. So, it is an uncommon malformation if mandible associated with excessive growth of one of the condyles. Local circulatory problems, endocrine issues, and trauma may be considered etiological factors in that. So, condylar hyperplasia, it manifests as facial asymmetry, prognathism, rosebite, and open bite. In radiographs, some patients have enlargement of head or neck of condyle. Treatment. So it depends upon the severity of problem and functional limitations. Some patients need unilateral condylectomy, whereas others need unilateral or bilateral mandibular osteotomies. In patients with compensatory maxillary growth, maxillary osteotomy is also needed. Condylar hypoplasia. Underdevelopment of condyle can either be congenital or acquired. Congenital condylar hypoplasia is usually associated with head and neck syndromes or mandibulofacial dysostosis. It acquired condylar hypoplasia that is most commonly caused by disturbances in growth centers due to trauma during infancy or childhood. Other causes are radiation therapy, infections, rheumatoid, and degenerative arthritis. Clinical and radiographic features. So it can be unilateral or bilateral, producing a class 2 malocclusion. In unilateral hypoplasia, mandible shifts towards the affected side when the mouth is opened. TMJ or the temporomandibular joint ankylosis may be developed in case of trauma. So here it shows the radiographic features. Ankylosis. So next one is, so it's treatment. It depends upon the severity of the problem. Is the condyle is missing, and the costochondral rib graft can be placed to help establish an active growth center. Osteotomies can provide a cosmetically acceptable result is in some cases. Exostosis. So these are localized bony protuberance that arises from the cortical plate. So usually they affect the jaws. Most commonly reported exostoses are the turus palatinus and the turus mandibularis. The turus palatinus, so it is the bony protrusion on the palate. So it is a common exostosis that occurs in the midline of vault of hard palate. Both hereditary as well as genetic factors play their role in its etiology, and when a threshold level surpasses, the trait appears. Its clinical and radiographic features. So it represents as a bony mass that arises from the midline suture of palatal vault. Mostly, though are small and measuring 2 cm, they can increase in size. They may be classified as flat turus, spindle turus, nodular turus, and lobular turus. So its histopathologic features. So microscopic examination reveals a mass of dense linear cortical and bone and an inner zone of trabecular bone. Treatment. So biopsy is rarely indicated as they are diagnosed clinically. In edentulous, they need to be removed because they create problem in denture making and wearing. So surgery may also indicate it in a situation where they get repeatedly ulcerated or inflamed. So the turus mandibularis. It is a common exostosis that develops along the lingual aspect of mandible. Its cause is multifactorial, both genetic and environmental factors. It is a bony protuberance along the lingual aspect of mandible above mylohyoid line in premolar area. In 90% case, it's bilateral. So mostly it presents a single nodule, but it may present as multiple nodules. In radiographs, large turi appear as radiolucency covering the roots of teeth. So its histopathological features, it is same as other exostoses. So a mass of dense lamellar cortical bone and an inner zone of trabecular bone. Next is the treatment. So biopsy is rarely indicated as they are diagnosed clinically. In edentulous patients, they need to be removed because they create problem and denture making and wearing. Surgery may also be indicated in a situation where they get repeatedly ulcerated or inflamed. So the Eagle syndrome. So it is also termed stylohyoid syndrome, styloid syndrome, stylohyoid syndrome, or styloid carotid artery syndrome. So it is a rare condition, commonly characterized but not limited to sudden sharp nerve, like pain in the jaw, bone, and joint, back of the throat, and the base of the tongue, triggered by swallowing, moving the jaw, or turning the neck. So usually bilateral but maybe unilateral. So mostly asymptomatic, but symptoms may appear when nerve or blood vessels are compressed in that area. So commonly affects adults. Facial pain while swallowing, turning the head or opening the mouth. Dysphagia, dysphonia, headache, dizziness, and transitional syncope may be present. It may occur due to mineralization after tonsillectomy. So a second form of this occurs carotid artery syndrome or the stylohyoid syndrome. So the elongated mineralized complex impinge on external or internal carotid artery. Patient may complain of pain while turning the head. So treatment. So depends upon the severity of symptoms. For mild cases, no surgical treatment is required and local injection of corticosteroid may provide relief. For severe cases, surgical removal of the elongated segment is required. So the prognosis is good. Next one is the Crouzon syndrome or the craniofacial dysostosis. So it is an autosomal dominant genetic disorder known as bronchial arch syndrome. So congenital disorder of the skull and face. So it is characterized by craniosynostosis, the premature closure of sutures. So it is believed to be caused by mutations in fibroblast growth factor receptor 2. So the clinical and radiographic features. So brachycephaly or the short head, scaphocephaly or the broad-shaped head, trigonocephaly, triangle in shape, orbits are swallow resulting in ocular proptosis, visual impairment or hearing defects, maxilla is underdeveloped resulting in hypoplasia and crowded maxillary teeth. So skull radiographs show increased digital markings, so as you can see here in the figure. So treatment. So the clinical defects may be treated surgically but multiple procedures are required. Frontoorbital advancement can be performed to correct ocular defects. The midfacial advancement is aimed to correct maxillary hypoplasia. Next one is the Apert syndrome. So Apert syndrome, it is a rare syndrome characterized by craniosynostosis or the premature closure of sutures. So it is believed to be caused by one of the 2-point mutations in fibroblast growth factor receptor 2. So it is inherited as an autosomal dominant trait. So its clinical and radiographic features. So ocular proptosis in a normal finding, hypertelorism, downward slanting lateral palpebral features, visual loss, and occur due to chronic exposure of the pressure, increased intracranial pressure, compression of the optic nerve. So skull radiograph shows digital impressions like Crouzon syndrome. So the middle third of the face is significantly retruded and hypoplastics resulting in relative mandibular prognathism. The retruded size of nasopharynx may lead to respiratory distress in children. Middle ear infections are common, so characteristics lean defects to help distinguish Apert syndrome from other craniosynostosis syndromes. So Syndactyly of the second, third, fourth digits of hands and feet are observed. So it is trapezoid-shaped lips when relaxed. 75% patients show cleft palate or lip. Maxillary hypoplasia leads to V-shaped ridge and crowning of teeth. Class 3 malformation may develop. So, treatment. Cosmetic and functional defects of Apert syndrome can be treated by interdisciplinary approach. Craniotomy is performed in first year of life. Frontofacial is performed and midfacial advancement can be performed later. Coordinated orthodontic therapy is also required. So, the Treacher-Collins syndrome, or the TCS, it is a mandibulofacial dysostosis. So, defects in the structures derived from first and second bronchial arch. It is inherited as autosomal dominant disorder. It has a 60% of the total mutations occur due to increased parental age. Its clinical and radiographic features. So, zygomas are hypoplastic, resulting in narrow arches and depressed cheeks. It has a 75% patients exhibit coloboma. It is a notch on the outer portion of lower eyelid. So, all side effect or absence of the external auditory meatus results in hearing defects. So, mandible is poorly developed, resulting in markedly retruded chin. Radiographs often demonstrate hypoplasia of the condyle and coronoid process. Cleft palate is seen 1/3 of the patients. Parotid glands may be hypoplastic or absent. Treatment. So, the patients with mild form of disease may not require any treatment. In severe cases, multiple surgical procedures are required to cosmetically improve that defect. So, that's all, and yes.